Endometriosis is a disorder that affects far too many women. It is a chronic, inflammatory, estrogen-dependent condition that can markedly impact the quality of a woman's life. It is defined by the presence of lesions of endometrial-like tissue outside the uterine lining. It doesn't just affect the pelvis, but can affect multiple systems in the body, cause pain, infertility, sexual satisfaction, and work productivity. The vast majority of women affected are in the reproductive age, but it has been reported in girls prior to their first menstrual period and in postmenopausal women as well. The prevalence of endometriosis ranges from 0.7% to 8.6% in the general population, been observed in up to 68% of women with subfertility, and up to 70% of women with chronic pelvic pain. In other words, endometriosis affects roughly 10% or 190 million women of reproductive age, women and girls globally. Welcome to GynoCurious. I'm your host and creator, Dr. Amy Novatt. From both sides of the speculum, we're here to investigate what it means to be a healer and to be healed. Please, if you have any comments or questions, please write to radiofreerhinecliffe.org, or if you're interested in my clinical practice, please go to dramynovatt.com. Please follow the show, share the show. We love doing the show, so please support us by doing that. So today I am speaking with Nicole Notar. She is the founder of Vindicara, a clinical decision support infrastructure company designed to integrate directly into hospital electronic health record systems to support earlier identification and structured care pathways for the diagnosis of endometriosis and adenomyosis. Hi, Nicole. Welcome.
Hi, thank you so much for having me.
It's my pleasure. I've looked forward to speaking with you. So
Likewise.
first, I guess I'd like you to describe Vindicara in other words. So that's a
Yes.
mouthful for people who don't know about electronic health records. How
Yeah.
would you how would you describe this work that you're doing right now?
I think the best way to describe it is just how I came about it through my own patient experience.
Great.
So like you said, I love that you included in the definition of endometriosis that it can, you can have symptoms and it can exist prior to menstrual cycles and postmenopause, because that's very important and most people don't know that. But yeah, I am one of those patients that my symptoms started at 9 and I didn't get my first menstrual cycle till I was 11. So definitely, pre-menstrual cycle endo. Well, I guess long story short, I had surgery 3 years ago, excision surgery, and it took over 15 years to get there. And when I finally recovered, I'm like, why did it take me so long to find this
Mm,
doctor? Why did I have to go out of network? Why did I have this surgery not even knowing the difference between ablation and excision? Why did I have this surgery not knowing that endo was a full body disease? I thought I was going to be in and out same day. I mean, that's what the original plan was. In and out same day, 3 hour surgery. The way I relayed my symptoms, they're like, maybe you'll have like one or two lesions up against your bowel and we'll remove those and you should see some improvement. Ended up being a 7 hour surgery. I was in the hospital for 3 nights. And then I live in New Jersey now and my surgery was in Manhattan. So I wasn't cleared of bowel perforation. So then they wanted me out of the hospital. So I was in a hotel near the hospital for the extra 3 days. So I ended up not going home for a week. And the
okay.
surgery was double the amount of time. And they found 73 lesions in my whole pelvic area. So bladder, I didn't know that was a thing. Bowel, obviously, but the colon and the rectum, deep infiltrating the colon, hence the hospital stay. Both abdominal sidewalls, the ureters, the appendix, they just took that out, encompassing the uterus, and both fallopian tubes. They were covered in endo and distorted, and then both ovaries were both deep infiltrating endometriosis with two huge endometriomas. One was larger than the uterus. So definitely obviously a full body impact. And I had no idea. I thought I was going in for surgery to help my period pain. And that after that, then I would have to go further down the road for my gastro issues. So I'm just like, how did I've went down the whole road of, diagnosing yourself and teaching yourself like down the rabbit hole of researching and going from doctor to doctor to doctor and all these different specialists and holistic care. if it exists, I tried it. Like if there was something online that said this could help endo, I tried it. And just having that, having the access, like I was able to go to an endo specialist in the city and it wasn't a problem. Like, how did I not find that sooner? I was in the best position possible and it still took that long. So after that, I'm like, how could somebody who doesn't have a 401k to drain get this surgery, who doesn't have, a partner who can, help out with small things when you're recovering or, take you home from the hospital and stay in the hotel with you, like all those different things that like a lot of people sometimes could take for granted. And I'm like, I need to fix this. So I reached out to a bunch of endometriosis foundations and I was just like, I want to help women pay for surgery. Like, that's it. Like, do you guys do that? Can I raise money for that? And every single foundation I reach out to is doing amazing work with research and advocacy to help on the policy side. But that takes a very long time, of course. So, like, in the meantime, like, who's doing that missing puzzle piece? So I tried to build it under already established foundations and it just wasn't working. So I'm like, I'll do it on my own. So I started a foundation called EndoExcisionForAll, and all the way 100% of donations go to a patient surgery fund. So that's how I really threw myself into the world of endometriosis while still working my full-time marketing job. And then over time, as the foundation grew, I'm like, I need to really, like, I'm just looking at all these patients and like every story was getting worse and worse and scarier. I'm like,
Mm.
I didn't know about thoracic endometriosis throughout my own surgery. Like I was learning about that and just all these different situations that women are in. And these women who are, I'm just about to turn 30 and I'm talking to women who are 45, 50, 60, 70, and just the ringer they've gone through. And they're only hearing about endometriosis now. Like to 65 years later, you're learning about endometriosis. That's a gap in the system. So I'm like, I'm a patient. I'm I can't go to med school. I pass out at the sight of blood. So that's not an option. So I'm like, how can I infiltrate the doctor's office without becoming a doctor? So I have a little bit of a tech background. Like what I've been working in the last 10 years is marketing business development. So I'm like, all we need to do is flag it. Like obviously provider education. And there's a million things, right? There's a million things that need to be shifted in or changed in endometriosis. But like what I can do is work with software and try to develop a software that will help doctors who are not trained on endometriosis fully. We know that's the case. We know unless you do continued education, a provider is not fully caught up at endometriosis from med school. There's not enough time. It's not their fault. I always say a gynecologist can be the number one person you want to deliver your baby or the number one person you want to go to for any gynecologic issue, but not for endometriosis unless they've done that continued education. And that was just the thing for me. I'm like, I just want to flag endometriosis. Like that's the starting point. We just need to get the word out there sooner and we need to show providers why. And I'm like, they don't listen to the providers that aren't diagnosing endo or even bringing it up are not listening to us patients, right? That's why we're going through the ringer and going from provider to provider and feeling lost. I always say we're like broken toys and you're just going from one toy shop to the next. That's what it feels like. And you go to one doctor and it's like, oh, here's a script for this and that fixes your arm. And then you go to the next doctor and oh, here's a script for this and that fixes your leg. But like you're never fully fixed. And that's what needs to change. So from my experience with providers, obviously on the patient side, not listening to patients majority of the time. Then, like once I got involved with the foundation and the policy side and going to conferences and endometriosis events and ACOG events and all these different like medical provider events, seeing that a lot of these providers don't even listen to each other because it's so competitive.
It's
So I'm
so
like,
true.
that's an extra added layer. So say you can be in, oh, this specialist said that you have it. Well, I don't think so. And like, that's a whole other thing. So the patient's just lost in the shuffle. And I'm like, what's the one way to maybe infiltrate the office and kind of work with that ego? And I'm hoping that answer is software. So I'm creating a plugin that will integrate into my chart and other EHR systems, but obviously Epic's the big boy, and just flag endometriosis. So when they're typing in the notes, and this came about as I was going through my own medical records, and
Mm.
from something that happened during my surgery process when I had my consult with my excision surgeon is I had imaging. I was like, I had stacks. I'm reading everything I have. Like I was so desperate. So I had my imaging from when I was 14, 15, 16 of, my like ultrasounds of my ovarian cysts that's when I started having the cysts. And I was in the ER all the time. They're like, oh, they're free fluid, cyclical cysts. Like they come and go. They shouldn't be causing this much pain. Here's some naproxen. Like go to school. And I took the same
Mm.
imaging and showed it to the endo specialist. And he's like, those are endometriomas. Like it's clear as day. And like,
Wow.
how did know? I went everywhere. Like, name a gynecologist in the Northeast. I was in their office, and
Yeah.
none of them flagged endometriomas. No ER I went to flagged endometriomas, and I was there a lot. So that's the problem. So like that's where it needs to be flagged. So if there was something that was in an Epic, in my chart, or in whatever the HR system is, that will just pick them on the doctor's notes. I'm going through the notes and they're saying, inpatient, doesn't want to, I forgot the exact verbiage, but basically like doesn't want to listen, doesn't want to try birth control. If you tried 3 birth controls and had horrible experiences, like that's not fixing the problem here. You can't just
Right.
trial and error me for the rest of my life. Like, what is the root issue? I can go on a birth control that suppresses my period. The game plan at the time was to go on a birth control where I only got my period 4 times a year. I'm like, but that's eliminating how often I'm dealing with the pain, but that's not eliminating the root
Getting
issue.
rid of the pain. Yeah. Yeah.
That's not the root issue. And what about the daily symptoms? Like, it's not just with the period, it's also daily.
So you brought up so many issues that I want to address. And I guess I want to just go back a little bit because as you pointed out, and I also pointed out, the majority of women who are diagnosed with endometriosis finally, eventually,
Yeah.
are in the reproductive age. What was going on with you when you were 9? What were the symptoms that you started having then? I'm curious.
Gastrointestinal and bladder. So I was getting
Okay.
UTIs left and right,
Okay.
constantly, and
Okay.
gastrointestinal.
So, why don't we tell the audience kind of what are the symptoms that are kind of typically described by the person who has endometriosis? Because I'm sure those are the words that your technology is picking up on,
Exactly.
the flags, if you will. So, if someone's listening out there, what are some symptoms that you want to make sure they're aware might be a sign or a symptom of endometriosis? Can you kind of give us a list of that, Nicole?
It's the top 3: painful menstrual cramps, not normal. No
Mm-hmm.
matter who says it's not normal.
That's right.
IBS. I saw something the other day, I think it's like 80% of women with endo first present as gastro symptoms before any reproductive symptoms. IBS and ovarian cyst.
Yeah. Yeah. So the reason that I want to make sure that we speak out loud about the symptoms, and the symptoms can be, so varied from urinary to menstrual related to discomfort with sex to pain with bowel movements to painful deep intercourse, fatigue, infertility, and then, of course, all the emotional and mental ramifications of feeling like shit for month after month, year after year. So the trouble with endometriosis from a clinical point of view that a lot of doctors will use as an excuse is, oh, wait, I just thought it was IBS. Oh, I just thought it was a functional cyst. Can we talk a little bit about that, Nicole? Because some people, there are clinicians out there who are thinking of endo, but they still are being distracted by other diagnoses. So I want listeners to know it sometimes can be tricky.
Yeah. It's especially with the gastrointestinal. It's like, all right, let's do a colonoscopy. Let's do this and let's try this medication. Or even with the menstrual side, like let's put you on Lupron and just shut everything down. That's a red flag.
Well, what I want to point out is that I totally agree with the fact that there's competition amongst physicians. There's a lack of education. There's a lack of time. The system, gosh, GynoCurious talks a lot about the dysfunction of the medical milieu right now and how we're not really addressing women's needs. And then, may I mention all of those years, decades, centuries, where women's complaints were completely dismissed. Oh, she's just hysterical. Oh, she's just tired. Oh, she just is in a bad mood. Or, oh, she's just on the rag, right? So there's a lot of reasons why our stories, our narratives, our physical symptoms have just been poo-pooed over a lot of time. And then you combine that with the challenges of lack of education in doctors and clinicians, lack of time, etc. But the other component that I want to make sure folks understand is that there are conditions that give symptoms like endometriosis that are not endometriosis.
Yeah.
And that's
Yeah.
that's what I want to make clear. So that's sometimes why also there can be, I mean, the data I've read, it can take sometimes up to 12 years, maybe even longer, for women to get a definitive diagnosis of endometriosis, despite years and years. And it sounds like like annually, we're complaining of things.
Yeah.
So
You'll see in the ICD-10 charts like IBS, vulvodynia, interstitial cystitis,
cystitis.
yeah. And even, I mean, the other thing that I'm learning more about now is the pulmonary side of how many
Mm,
patients go through pulmonologists, and their lungs are collapsing on their cycle, and that's just completely ignored because
yeah,
like nobody really knows the tie to it unless you did continued education or you're a
right,
patient who learned from other patients. But yeah, that's what makes it so complex is like you can get diagnosed with so many. I mean, even IBS. It's just we ruled out everything else and your bowel's irritable. It's like you don't have a scan that says positive for IBS. It's really just a
right,
label. Um,
right,
and so, I mean, a lot
right.
of these pelvic pain conditions are. So yeah, that does make it extremely complex. But
Yeah,
I think part of it is seeing it all as a whole. Like, okay, if it's just IBS and you have no other problems, then okay, maybe there's just maybe it's not endo of the bowel. But if it's a combination of everything, like you're getting chronic UTIs, painful intercourse, IBS symptoms, rectal bleeding, feeling like your chest is like, shoulder pain on your period and feeling like you're short of breath on your around your menstrual cycle, back pain, the sciatic pain, leg pain during your cycle, all these things. And I think that's the other key component too is how cyclical they are. If it's worsening when you get your period, that says something.
yeah. Yeah, exactly, exactly. And the reason for that, those listening, is that what we know about endometriosis, and we don't know everything about it, is that it is estrogen related, that estrogen is the hormone that kind of feeds it. And again, we know that menstrual cycles can be so intimately related.
Yeah.
So the other thing that's so interesting, curious, and challenging about this condition is that when we do make the diagnosis, sometimes it's incidental insofar as that we might go in to do the removal of an appendix and we look in the pelvis and there's endometriosis, but
Yeah.
the lady is not talking about any symptoms. At the same time, we might go in and do endometriosis surgery and someone has, some complaints and we suspect it and we look in and their pelvis is full of it. So it's also one of these diagnoses where the symptoms and the findings can sometimes be mismatched, right?
Absolutely. I think there's a two-part there. So actually it's funny you said that because that's how my mom was diagnosed. I was born a
Mm.
C-section, and when they were delivering me, doctors like that looks like funky tissue and it tested positive for endo. So that's how I ended up knowing what the word was as I got older. So I think that's part of it too. It's like a twofold is if you don't know endometriosis is a full body disease, then you don't know the symptoms to relay in the appointment. So if you're sitting in a gynecology, this is what I see all the time with the patients that I talk to at the foundation, and this is my own like my mom personally that has endo and taking her to doctor's appointments is sitting in the gynecologist. I think people have or I've seen that people have a mindset or an expectation that they should only be giving gynecologic symptoms. And then they exclude the gastrointestinal ones, exclude the bladder ones, exclude other one, or back pain, things like that, that all feed into endo. Like that, you need that. Like you have to give all the symptoms no matter what doctor you're going to. Even when I go to the gastroenterologist, it's important to say, hey, I have stomach aches all the time, but when I'm on my period, like they are horrific. That matters. And also, I'm getting UTIs a lot. Like, do you think there's something going on here? And making sure that you're telling every single provider because they need to know the whole story. How can a provider really help you fully if they're only getting different puzzle pieces? They need
Yeah,
all of
we've
it.
become so siloed, right?
Yeah.
The GI doctor only asks us about our bowel and doesn't ask us about these other things. And, we are one body. And so often disease states affect a lot of systems. And so there's something called the review of systems that every doctor should be doing. If you go to your gynecologist, they should be saying, is there anything going on? Your eyes, your ears,
Yeah.
your nose, your throat, your heart, your lungs, your skin, your mood. Basically, I have this little sing song that I do because I want to know what else is going on. But again, when you're seeing a doctor for 10 minutes, they often aren't asking those questions because they don't have the time to address them, which is really a problem. So yeah, I think, Nicole, what you're pointing out, and so often I have this conversation on GynoCurious, is that we have to be our own patient advocate, right? And that what helps, particularly if as you're listening to us, you're thinking, oh my, I think I might have endometriosis. Write down all your symptoms. So the next
Yeah.
time you go see your clinician, whether it be your
Forget.
primary or whatever, you can even hand them that list and you say, I need you to know that this is a concern I have. And I'm not diagnosing myself. I'm just suggesting that's something that we talk about. But you mentioned something else that I really want to talk about because it's such a problem in medicine. So many gynecologists have, they know about endometriosis. Family doctors know about endometriosis, but don't really know
Yeah.
about endometriosis. So, what would you say to our listeners around if they're concerned, if they have a suspicion that endo is a part of their life? Like, where do they go? What do they do? What would be the path down which you would recommend they start and perhaps end up in?
You have to go to endometriosis specialist. There's obviously you need your gynecologist. There's many needs there. I'm not discounting gynecologists at all. You
Right,
need them.
right.
But when it comes to
Hmm.
endometriosis, that is not there. It's beyond the scope. You need to be with the endometriosis specialist who did the continued education, the 2 years of fellowship just to learn about excision. Like that's how complex it is. You need to see somebody who's doing excision like that's all they do. They just do endometriosis. They are not delivering a baby on Monday and doing an excision on Tuesday. That is a giant red flag that the person is not a true endometriosis specialist. And it gets really hard to tell because that was an issue I had going through. I had United Healthcare at the time, and I typed in endometriosis, and all these gynecologists
You
show up,
bet.
and I went to all of them, and they didn't know anything. One of them said, "You don't look like you have it." So everybody thinks they have it. I'm telling you, you don't. I went back to that one with my pathology report, and basically she just rolled her eyes and was like, "I'm happy you got the help you needed." I'm like, "But are you going to learn from this? Are you going to learn not to look at somebody to determine that they probably don't have endometriosis before even
Oh,
listening to them?" And that's just one story. I can go on and on, but that's the biggest issue. I mean, there's a million big issues, but you know what I mean? That's a giant one that it's so hard to know if you're with a real specialist.
yeah. So I want to make sure that we talk about some of the basics of endometriosis, but I guess while we're there, so how do people find endometriosis specialists? Where do they go? How do they find them?
So I'm building a directory through the foundation,
Great.
and also on Vindicara, so dual purpose there. But yeah, just vetting that. I mean, through the foundation, like obviously I'm meeting a lot of these providers and
Hmm.
watching their patient. It's like having patients that have gone to them and can, attest to their expertise, but then also just knowing their expertise, so how they trained, where they trained, who they trained with. I mean, the major one, if they did continued education after medical school, focus on endometriosis excision. All you have to do is ask a doctor, is ablation good or bad for endometriosis? And if they say no, they're good. Like, you're in the right place. But that's even tricky. I mean, I've had so many patients that apply for help for paying for an excision surgery through the foundation, and they'll tell me that their last surgeon, they thought they were the specialist because they asked them, "Hey, you're going to do excision, right? Not an ablation?" They said, "Yeah, yeah, we do excision here." And then they got their pathology report and they excised 2 lesions and did ablations on 13. So there's not even thorough communication. It's disheartening. It's scary. There needs to be, and through the foundation, we're working on this on the policy side, but like a real fellowship, like we have MIGs. Why is there not just an excision fellowship? That's what we need so that people know that they are in the right hands. Right now, you're just going through reviews and trusting that you're with the right person. I mean, the biggest flag right now is if the person's out of network, they're probably legit because they
What a
can't.
remarkably disturbing reality, isn't that?
Absolutely. And that's a sad state of affairs that we're in. That's what we're trying to change. But that is the reality. If an endometriosis specialist is out of network, that means they're doing excision, because if they're doing ablation, they would submit it to insurance and get paid. They have to go out of network because the reimbursement rates are so low. They can't do a 7-hour surgery with what the reimbursement rate is for CPT code 58662 that covers ablation and excision. They can't. So it
So I'm
forces
going
them
to
out of
stop
network.
you there. because I think that we need to break this down a bit.
Yeah.
For folks listening, there are a variety of different so-called treatments for endometriosis. Historically and currently, women are offered nonsteroidal anti-inflammatories for their pain. They're given hormonal medications that either stop their periods. So, as Nicole described, she has pain less, or a person has no pain because they have no periods. That there are medications that work on blocking hormonal receptors that can be, we call them GnRH agonists and antagonists. We're using aromatase inhibitors, so a whole array of medicines to help reduce symptoms. But none of these interventions eradicate or get rid of endometriosis, correct?
There's no cure for endometriosis. You can excise
That's
it,
right.
but doesn't mean it's not going to come back.
That's right. So now you've been talking about ablation versus excision. Can you explain to the audience what you mean by those two different surgical approaches and how they are different and what you know about why excision is better, please?
The endometriosis lesions are like an iceberg. It goes deep. It goes cuts deep into the water. So if you're taking an ablation, which is thermal, basically you're burning the lesion
That's
to
right. It's
surface
taking
level.
heat and just eradicating it, burning it on a very superficial level. Yep.
Exactly. You're burning it on a superficial level. So you're not getting into the root of it. So it's going to pop like a weed in the garden. It's going to pop right back up if you're just cutting it. But excision, you're excising it, you're going into the roots, you're digging it out from the bottom. So you sometimes, like in my case, I had to dig into the colon and excise it from there. If they had just done an ablation, it would have come right back a couple weeks, maybe. Like it's not, I don't know the exact timeline, but it's less of a recurrence rate when you have excision done. Everywhere, there's so many different stats on that. Every surgeon I've spoken to has a different number, but some are like 30%, 40%, somewhere in there of the recurrence rates. Different per surgeon, of course, but you have a less likelihood of needing another surgery if you get an excision, or if you need another surgery, it's further out than if you get an ablation. So like I had excision 3 years ago. I'm about to gear up for my second one. So I expected about 3 to 5 years, and here we are. But ablation is way faster. It's also, that's the other thing when it comes to the coding. So ablation on average can take about an hour, where excision, it can be an average of 6 to 8 hours. It can be 3, it can be 12, depending on the case, but on average 6 to 8. So with the reimbursement rates being so low, these surgeons who are doing excision, they can't submit through insurance. They have to go out of network. They can't keep their lights on. They can't pay for the OR time with the reimbursement rate being so low for a 7-hour surgery. It's impossible. So that it forces them out of network.
And, there's science to demonstrate that excision is better than ablation.
Yeah.
And so the fact that the insurance companies are able to exploit women like this in terms of, we'll only pay for this. And think about the vast majority of women are not going to be able to afford excision surgery. They just can't. And so it's just criminal, quite frankly, I think, that these insurance companies get away with this. So folks are asking, I'm sure they're saying, okay, so what causes endometriosis? Why do I have it? And I want to make sure that people understand that we don't really know. There's all kinds of theories about it, kind of a complex interplay between steroidal hormones, immunologic, inflammatory, angiogenic, vascular, and environmental factors. And then the only thing that we do have information about are the genetics.
Yes.
So you mentioned your mom had endometriosis. Now you have it. I actually have the same situation. I had endometriosis, and I suspect my daughter does too. And it's a miserable thing to pass down. So again, I think that for those listening, if you know that your mother, your sister, your aunt suffered from this disease, please, that's another reason to seek out help. Yeah.
That's something when I was going through my high school years is when my symptoms became really debilitating. And just to touch on what we talked about before in terms of what to say to the provider when you're in your appointment, the biggest advice I feel like I can give is to emphasize how debilitated you are. To say you're uncomfortable, it's not the lights aren't going to go off. It's, okay, you're uncomfortable. Here's some naproxen. Oh, this sounds hard. Here's a Zoloft. Or, all right, we'll just switch your birth control and check in 6 months. No, it's debilitating. You are missing school actively. You're missing work. It's affecting your relationships, friendships, romantic life. It is debilitating. That is a big emphasis point.
So, Nicole, is there anything that women out there can do to reduce their risk of endometriosis that you're aware of?
Anti-inflammatory, but I don't think that's reducing the risk of endometriosis. I think that's just pain management.
Right, it is. And that's the other thing is that remember, there's kind of two well-defined group of women that we're talking about. There's the group of women who just please, please, please get rid of this pain
Yeah.
of all these different sorts. But then there's the group of women we haven't talked about yet, and those are the women who are trying to get pregnant.
Yes.
And that's a whole different approach or way of thinking about the endometriosis because there's all kinds of conversations in science looking at the role of excisional surgery even before in vitro fertilization is tried, etc. I don't want to get too much into that, but I do want those listening to understand that again, part of this conversation that Nicole and I are talking about in ways of preparing when you see your doctor is thinking, am I at a place in my life where I just want to feel better? Or am I at a place in my life where, I've heard endometriosis affects my fertility potentially, or I've been trying and trying and trying to get pregnant and I'm not.
Yeah.
And they're two different groups and two different approaches and in a way, two different requests, right?
I think the most important thing to acknowledge there is that you can have well, I use asymptomatic loosely because then infertility would be the symptom, but you can have asymptomatic endometriosis where you're not feeling the symptoms, but then your symptom is infertility. So then there's so many women that are like, oh, I've never had painful periods. Like, I don't have IBS. I don't have any of those problems. So I can't have endometriosis. I've been struggling to get pregnant for a year. I'm not saying that's the cause, but it could be. That situation
Right.
has happened a lot.
Yeah. No, it's really important that folks hear that you may be the person who has no symptoms, the obvious symptoms, but yeah, you're trying to get pregnant and not. And what a good reproductive endocrinologist will do is rule out all the other obvious reasons you may not be getting pregnant, a male factor in addition, but then think about the possibility that endometriosis is blocking the tubes so that the egg and the sperm can never meet, or that ovulatory experiences are deficient or maybe not even happening. So there are lots of ways to evaluate for infertility, but it is something to always think about. Okay, I'm a lady out there listening to GynoCurious and I'm thinking, man, I think I have endometriosis. I'm going to go see an endometriosis specialist because I'm going to go to Nicole's website and learn what I need to learn. What can they expect will happen when they go to the doctor, Nicole?
To the endo specialist,
Yeah, what will the doctor do?
being
Are they going
listened
to get
to,
blood work? Oh, yeah,
being
right
listened
on.
to for the first time.
Okay. Yeah.
Simple as that. That's just being listened to, having a conversation. When I had my first consult with an endo specialist, I left there crying, and it was the first time I was crying
Mm,
happy tears leaving a doctor's office. And I scheduled surgery. And I'm like this, but I was so happy to just be sitting there. And he's like, "Oh, what's your pain scale? And 1 to 10." I'm like 110. And he's like, "Okay, that makes sense. Like let's dive deeper into this. Tell me more." And sat for an hour and just went through everything. No labs happened. Eventually, obviously, pre-op, you have to get labs and whatnot, but that consult was just conversation. And it was going through from 9 years old up until at the time I was 26, everything, the symptoms, my high school years, being in and out of school, having everything blamed on mental health. That's for a story for another time. But yeah, just being listened to and
being
then being
validated.
validated,
Yeah.
having the explanation. I think that's the other thing too, and that's something I always struggled with. Any doctor, but specifically with gynecologists, is I'm not anti-birth control at all. I'm on it right now. But I really struggled with starting it when I was younger because I'm like, you're not giving me a reason. You're not telling me
Mm,
what, you're not doing my hormonal blood panel and telling me I'm high in this and low in that, and like this is going to balance me out. You're just writing a script like it's candy and giving me zero background, zero information on what to expect, zero information if I have side effects, how long should I ride about for before, all right, this isn't the right one for me. And then
right.
what's the plan after that? And what is the purpose of this? And that's like what we talked about before, shutting down the pain or minimizing the amount of cycles. But that was a big issue for me, was not having the communication with the provider to understand what their treatment plan was. And that's
Absolutely.
something with the endo specialists, my own individual one and all the ones I've met and have had patient verified by other patients, is just the explanation, just like drawing it out. Literally, a lot of them like have whiteboards and they just draw out like, oh, you have painful intercourse. Well, this is why, because you have lesions, if you have lesions here in your peritoneum and your, penetration with intercourse, of course it's going to hurt. This is what's
Yeah.
happening. And
Yeah.
all right, here's your bowel, here are your ovaries, here are your flow, like drawing it all out and really
Yeah.
painting the picture so you can try to understand what's going on in your body and what's causing the pain. Not that that takes away the pain, but at least it develops more trust with the provider. It gives you hope that there's an end to the pain, that you're on the right track. If you have endometriosis, you've been gaslit medically and probably by friends and family when you keep canceling and they don't understand why. Like you have
Yeah.
experience with gaslighting. So it's absolutely priceless to be in a doctor's office where you're not being debated.
Yeah. Well, listen, information is empowering.
Yeah.
And yeah, it may not get rid of your pain, but boy, when we understand what's going on in our bodies, we feel more in control. We at least then say, okay, I'm going to create strategies now that I understand the problem. But I want to let people know that what happens when you walk into a doctor's office, thank goodness, is Nicole found someone who listened to her, validated, but also you're going to have an exam. It's going to be recommended you have some kind of imaging, most likely. And,
MRI,
usually, yeah, you start
transvaginal
with
ultrasound,
ultrasounds or
MRI.
MRI. And then there's a conversation about surgery. So you're not going to surgery the moment you walk into a doctor's
Oh no.
office.
I
And
always say
moreover,
I always say that to patients too. I'm like,
yeah,
just because you're making an appointment, they're all surgeons, obviously, but just because you're making that appointment doesn't mean that you're leaving with a surgery date. Like it's
right.
important, even if you're not ready for surgery, to be under the care of a specialist and even to get, if you want to stay on birth control, that's, you're like, you know what, I want to try one more. I want to see if I, can manage the pain and not have to jump into surgery in the next year or so. It's better to be under the care of an endometriosis specialist because they can understand it better. And when they're prescribing you birth control, they're prescribing it with the knowledge of endometriosis and what it will do for your body, not just whatever script you know,
That's right.
they funnel
That's right.
through their practice.
Right.
It's
What
completely
samples they have
different.
in their back closet. That's
Exactly.
right. That's right. So, again, I think the message I want to leave with folks is also that not everybody is going to have excisional surgery.
Yeah.
That's not what we're talking about. We're talking about kind of the approach towards as much eradication as possible. But again, it's an expert's opinion combined with your wishes, your hopes, your understanding of where you are in your life. Again, is it about getting pregnant or is it about helping my periods be a little less painful and I have no other symptoms? Well, then maybe a birth control pill continuously taken is the right choice for you today. It may not be the right choice for you 3 years from now, but it's about what's going on with your life here and now. So we're getting towards the end of our conversation, and I want to make sure that everybody knows, first of all, what is your foundation again? How do they find you and EndoExcision for All? Let them know, please.
Yeah, endoexcisionforall.org. And on social media too, all our accounts are like at EndoExcisionForAll, endo, ENDO, excision, and for all. Yeah, but
Is that
it's
is that the digit four or is it
written
FOR?
out, yeah, FOR and then
Okay.
AL.
Okay,
Um,
great.
yeah, our main, obviously, funding for surgeries, but even just walking through the whole practice, so or the whole journey. So going from I need to find a provider, or like we just said, I don't want to rush into surgery, but I need to talk to somebody who knows what they're talking about and see what like make a game plan. Just the whole mental side of processing when you've
Mm.
struggled for 30 years and you finally have surgery, you're like, oh my God, what is this? What is this disease? What does it mean? What do you mean there's no cure? What do you mean I might need another surgery? The whole mental side, just walking through that, walking through the insurance. I mean, there's some patients with some providers that try to maneuver working with insurance, the gap exception. So that's a way to fight insurance to try to get approval. I sit on the phone with patients for hours with their insurance companies, fighting, writing letters, walking through that process. Because it's if you've never dealt with this before, the insurance companies, they don't want to cover anything. Like we have to fight. And it's like, knowing the right verbiage and what department to get to. And same with the hospitals. I can't tell you how many patients that we have funded. Everything's taken care of. And it's the night before surgery, and they get a phone call from the hospital. We decided the hospital isn't a network anymore. So if you don't pay $30,000, which is a self-pay discount from 99,000, we're canceling your surgery. And so many people finally lately, I think because we've been more public about it, so many women in the beginning have to like cancel it and then they call me. I'm like, no, call me first. I'm like, we'll get on the
Right,
phone,
right.
merge me in, we'll get on the phone with the hospital. That is absurd. We just have to fight them. And it's so sad that that's what you're doing the night before surgery is fighting the hospital. But when everything was said and done, but that's our state of affairs. So that's what we try to help patients with too. It's just not just the financial aspects, but the mental side, the dealing with navigating the insurance and the hospitals and doctors and all the things that go into it. It's way more than just writing a check to a provider's office.
Absolutely. I mean, what you're talking about is agency. You're giving women
Exactly.
information and support and community to have agency around their body and the diagnosis, and then, of course, the treatment. So I really admire the work you're doing because it's such
Thank you.
important work. So thank you, Nicole. Thank you for joining me. But before we say goodbye, I like to end Gyno Curious with, I guess, one question is there anything you want to make sure you say that you haven't said already about endo that you think people should know?
It's tiring, but you keep searching and being your own advocate, you'll get the right care. It's hard to find, but it's there.
Great.
And it's getting easier to find every year. There's more,
Good.
there's more surgeons coming about, there's more specialists coming about, and it's extremely tiring. I'm not dismissing it, but it's you just have to keep going. You have to keep going.
Right.
You can't just accept feeling horrible every day. You have to keep chasing it.
Great. So when you're not working so hard in your work and experiencing physical challenges, tell me one thing that gives you great pleasure.
Oh, the nonprofit and the startup, it's really been endo. Oh my Um,
Helping
honestly,
others.
now you're making me think I have to do more in my life.
Good.
I'm like, I might need to step back a little
Well,
bit.
there's a reason I asked this question
Yeah.
because so many of us don't spend time just receiving pleasure. And I'm not talking about just sexual pleasure. I'm
Yeah.
talking about taking a walk with our friends, throwing a ball with our dog, being outdoors, taking time away from the work that you so clearly are spending, so much of your time, effort, energy, spirituality,
Yeah.
doing and supporting others. So yeah, I think it is an opportunity for you after our call to think about one thing. And it's remarkable how much just a little bit of pleasure goes a long
Yeah.
way.
Yeah,
Yeah.
I need to step away and let the mind relax. I do. I
Yeah.
need to be better with that. I'm happy you
Yeah.
brought that up because I'm like, wait,
Good.
how much time has
Or
gone by? When was the last time I like went out to dinner?
yeah, yeah. Oh, make plans tonight.
Yeah.
Make plans tonight. Nicole, thank you so very, very much. I want everyone to know again, I'm speaking to Nicole Notar. Please look her up. Notar is the spelling of her last name. You can see it on our show notes. Your work is just wonderful. So thank you.
Thank you so much. I really appreciate it.
My pleasure. And thank you to Jen Hammoud and Maddie Rosenberg, my co-producers, and to David Hoffman, my editor. I also always want to thank the Epicurean who so kindly houses Radio Free Rhinecliff. And to all of you listening, thank you, thank you, thank you. Please stay well until our next episode. And please listen to your instincts and intuitions. They are the greatest of teachers, not to be ignored.